Professor Jagat is, I think, the initial person who brought pediatric cataract surgery in such a scientific way uh, to India, and sir has contributed a lot. He has written very impressive book on pediatric cataract surgery, which is, I think, read by all the people who are practicing pediatric cataract surgery. Sir, your lessons to everybody on pediatric cataract management.
Uh, Thank you, Professor Amit, for very nice introduction and for giving me this opportunity because it was sudden for me that when Dr. Parul Isvachani told me that you have to speak on lessons on pediatric cataract surgery. And I will be, whatever I have learned over the last 45 years in pediatric cataract, I will be giving only the outline of that. These pediatric cataract children, they come to us, and when it is absolutely clinically significant cataract, majority of them they have bilateral cataract, about 10 to 15% of them they have unilateral cataract. So each of the child, we have to keep in mind documentation or morphology of the cataract. Over a period, we have realized that what we have to do. You can say each of the child's eye we have to dilate to see the morphology, whether it is a zonular cataract or whether it is a lamellar cataract or whether it is a posterior lenticonus or whether there is PHPV. And you may find these subluxated cataract or lenticular coloboma, and these are the issues which can be ruled out or documented after dilatation of the pupil. Then what is important? Timing of cataract surgery. If it is an infant, particularly infant with visually significant cataract, mostly we operate 4 to 6 weeks after birth, provided child is fit for anesthesia. Early surgery particularly help to reduce amblyopia. Each time we have to counsel the parents because it is pediatric cataract surgery is different than the adult cataract surgery. So it is most vital whether it is parents or guardian, we have to do thorough counseling as we are performing cataract surgery in the growing eye, which differ from the adult. There are a lot of post-operative changes in the refractive error, and there is a need to change the glasses because there is change in the axial length of the eye and changing of the parameter. Then we have to also deal with much more complication, post-operative complications such as PCO, glaucoma, optic capture, myopic shift, and amblyopia, particularly in unilateral cataract, even sometimes bilateral cataract. And their follow-up is very, very important. When we should implant IOL, child with visually significant cataract, when visual axis is involved, and when not to choose IOL implantation or you choose aphakia. Indication: if axial length of the globe is 17 millimeter or more, if corneal diameter is 10 millimeter or more. When to choose aphakia? If axial length is less than 17, corneal diameter is less than 10 millimeter. If there is a microphthalmos, there is microcornea. And infant aphakia treatment study recommend implantation of IOL in children not less than 7 months of age. These are the children where there is a microphthalmia and microcornea. Cornea is 4 to 5 millimeter in these or so these are absolute contraindication for doing IOL implantation. These are some of the issues of concern in children, that axial length grow rapidly in the first 2 years of life. There may be marked capsular fibrosis. Posterior capsulotomy has to be done with anterior vitrectomy in younger children. Uncooperative for these children may be uncooperative for biometry. Spectacles compliance is an issue, and then of course amblyopia management. Then comes the optimal approach for determining the IOL power calculation in infant. These are some of the issues or the studies which you have to take into consideration. You have to keep the child hypermetropic, because child will develop myopic shift over a period of time as there is increase in the axial length of the globe. You may use handheld keratometer or this IOL master where the child is cooperative. Whether you use SRK2 formula, SRKT, Hofer, Haggis or Barrett, studies by M.E. Wilson has shown that it gives almost the same result. But over a period of time, we are using SRKT formula because initially we were using SRK2 or Barrett in most of the eyes which are grown. These are the Dahan's guidelines, which were when child is not cooperative for biometry, or otherwise, even if it is a IOL biometry is done, then we do under correction according to this formula, this guidelines, 20% in less than 2 years and 10% 2 to 8 years. But we keep a bit less than this because there may be much more difference in the post-operative outcome. So this is a very small video. This is just one small video clip which I will show. That we have to stain the anterior capsule with trypan blue dye. It makes the rexes easier, particularly for the beginner. And we make about 5 millimeter continuous curvilinear capsular rexes, and then multi-quadrant hydrodissection, and then removal of the cortex from the capsular bag. And then we make a little small nick in the posterior capsule after filling the capsular bag with viscoelastic, and make posterior continuous curvilinear capsular rexes about 3 to 3.5 millimeter. There may be no much vitreous disturbance, but limited anterior vitrectomy is done in the zone of rexes. And then every case we implant hydrophobic acrylic IOL. We avoid implanting silicone IOL in these cases. And each child you may place a suture particularly in the main incision. Post-operative follow-up, these children may need much more intense topical steroid and cycloplegic, repeated refraction and follow-up. That is mandatory in these children. And each follow-up we have to see whether prescription of the glasses has to be there, and amblyopia therapy, suture removal. Parent must ensure that child wear glasses. And these children are followed up for long time. These are the clear visual axis of the patients operated, but it is not always so. This is again clear visual axis, but you may get such fibrin over the IOL surface in the initial period. Sometime it may be toss or it may be inflammation, particularly in younger children. This may be, a child may get PCO, so you have to do ND-YAG laser capsulotomy, or most of the time it may be surgical capsulotomy. There may be such type of lens epithelial cells which you have to document each time child come, or it may be here again this is a PMM IOL and hydrophobic acrylic IOL. A child may develop optic capture or pupillary capture here, and they may have even this type of pigmentation of the IOL surface, or there may be iridocapsular adhesion. And occlusion therapy is mainstay to achieve the optimal outcome, especially in unilateral cataract. These, glasses, phakic glasses where child IOL is not implanted, how parents manage in JIA. So follow-up is very, very important. Surgery is the first step. The follow-up is lifelong. Treatment continues beyond surgery. Most importantly, the word of Ellis are worth remembering. Young children with an IOL in place are a unique clinical responsibility of ophthalmologist. Long-term follow-up is essential. This is a child of double crystalline lens which I have followed for 10 years. And another child, when this boy came, it was only infant, and now he visited me only few days back. More than 17 years of follow-up. And this child was operated in 1997, and this now he has completed his MBBS. That point of time, I did primary posterior capsulotomy and anterior vitrectomy, and he continued to have 6/6 vision, although there is a myopic shift, minus 1.75 and minus 1.5 diopter, that is helpful for near for him. So these are some of the issues which I can say. Okay, thank you very much. There are hundreds of the issue in pediatric cataract surgery, but keeping in view the time, thank you so much.
Thank you, sir, for comprehensively covering this vast subject of congenital cataract and pediatric cataract. Of course, there is nobody who can parallel the experience you have in this topic. Thank you for